Thank you very much for this very nice introduction notes to the organizers for organizing this wonderful meeting. It's very inspiring, and I had to change some things during the presentations for my talk. Before I start, I would like to let you know that I also have some conflicts of interest because I'm getting money in part from the industry. I think this is important to know because I give talks for the education of physicians, for example, and I'm also involved in many societies for working on guidelines. I would like to make the note that this is a personal point of view. I'm not an expert for large studies and for retrieving data and bioinformatics and all the things you need. But when I worked with colleagues in the field and tried to use data from cohort studies, I came upon a number of issues that made research difficult. Let me give one example. So I would like to shortly introduce the Lurk study as an example, because we have a study that is running now for 20 years, and we are currently in the follow-up for the 20 years follow-up to get the data, the causes of death data. And this is a typical example how in Germany, administration works and makes it difficult. So Lurk is a study that was, or the patients were recruited between 1998 and 2000. We have data for a follow-up of about 10 years and are currently trying to finalize data for the 20 years follow-up. The advantage of the Lurk study is that it is a cardiovascular risk cohort. So the patients had cardiovascular symptoms. The study is comprised of mostly men, some women, and the big advantage of the study is that we have a tremendous amount of data, not omics data only, but also biomarkers, physical parameters, and other health and disease parameters. So at present, the database contains tools. We have the causes of death from the death certificates. We have done whole genome association studies, and we also have done the epigenome-wide association studies. And so far, since its introduction, more than 280 publications have derived from this relatively small study. Before I prepared this talk, I was aware of Ishikawa diagrams, but I asked my PhD student to prepare something because she was observing a number of problems when she tried to get the data for the 20 years follow-up. That means just to get from the offices the information, how did the study participants die? I will make the story short and just highlight a few of these, number of things that made it difficult. And to be honest, COVID, the pandemic has made a serious problem for us because the offices responsible for these data are also responsible for registration of COVID cases. But nevertheless, within 3 years, we were not possible to finalize and get all registration data. And there are some hurdles which are, typically for German, I think. And one issue really is we are doing everything on paper. Not only COVID cases, also death registrations, and the transfer is done by letter mail. It takes time. Sometimes data get lost. And we have a serious problem in the moment because we have a time pressure, because after 10 years of storage, the data will be destroyed. Luckily, the people in the offices had not the time during the COVID pandemic to throw away the data, because the 10 years are over. So, but nevertheless, I don't want to go into details, but most of the issues are related to the human beings involved because it's a very administrative process to get the information. There's for sure data or general data protection regulation, not only in Germany, also in other countries, but I think in Germany we have a particular case that made it quite difficult to really obtain the data. So this is in principle a meta study. That means it's a collection of several data from several cohort studies, and it's a global study. So it was started in 1991 by Christopher Murray, and they document or started with a small number of regions and conditions and risk factors, but it progressed since then to a very tremendous effort because our initiative is now considering and analyzing 371 diseases and injuries, more than almost 3,400 or 500 clinical outcomes, in 204 countries and territories. Sometimes, or for some regions, also at the subnational level. That means they have information not only for the whole country, but to certain areas of the country. And it's a collaborative effort of more than 8,000 collaborators. And the tremendous task these people have done was that they developed all the tools and methods to harmonize data, to standardize the analysis procedures, and to retrieve data are helpful. So this achieved or resulted since then in about 2,000 publications, which have made a lot of progress in terms of changes of risk factors to the global burden of disease, also at the national level. And just to give you an example for the nutrition-related measures that are important, such as high body mass index, fasting glucose, blood pressure, and so on. And you can also obtain information on the dietary risk factors, such as energy or nutrient information, and to estimate their contribution to the overall burden of selected diseases. So as a collaborator, you're free to use the data, and this can be then used to make really nice things, such as this very general claim that, yeah, a poor diet is our most important risk factor worldwide. Yeah, so 20% of all people in the world die by an unbalanced nutrition. Yeah, and this was highlighted several years in a row by different media. And the publications behind this have been published in Lancet. So it's a very high quality peer review process of this tremendous amount of data. In my case, we also used this data to compare, for example, the effect of nutrition to cardiometabolic deaths in comparison to genetic risk factors. And the data from the GBD helped us to show that the diet is the major risk factor for cardiovascular diseases. Yeah, so this is a very important information, because for primary prevention and prevention of disease, this is a very helpful tool to make such data visible also for stakeholders, politicians, and decision makers. About 10 years of a healthy life can be estimated from the global burden of disease data if you conduct a diet that is balanced in comparison to our traditional diet. Or, and this is a very fast-forward approach, you can use these data for forecasting important issues such as life expectancy, years of life lost, or all-cause and cause-specific mortalities, as it is shown on the right side. So, and the most important thing for me is that the GBD is providing the access to the data for free. So you can register, you can use the data, you are asked to include and add data and to collaborate. And these information is provided via a web tool, which can be used with the current analyzed data immediately after publication of the basic papers of the study. Yeah, and this resulted in a tremendous increase in the number of important publications on the impact of risk factors worldwide. So this is a very good example how to do it, but as Christopher Murray has mentioned in a very recent publication, such efforts have limitations for sure. And this is probably something we have to consider, because we lack data. We lack data not only for low-income countries, we also lack data, for example, for Germany. Yeah, so for high-income countries. Also, we have to remind that all the data that have been included here in this initiative is coming from very different data sources. And this has been, has to be harmonized and to use fast-forward approaches that allow you to compare data from different sources. And just to show you here a short slide in which you can see that, for example, in Europe, some type of data is tremendously lacking compared to other areas such as North America. And from my personal point of view, just to give you an impression how really diverse our data is. So when we use the data for predicting the effect of the diet to cardiovascular complications, we use data that are almost 20 years old. So the last German nutrition survey has been conducted in the year 2000, 2005 to 2006. Yeah, we had a delay due to Corona, but mostly due to organizational and also to political reasons. We have no current national nutrition survey. So we do not know what the Germans eat, but we want to know the impact of the diet to diseases. Yeah, so it's in principle not really good science if you use such old data. So, and there are a number of other things such as, how to use, or which is the best approach to be used to compare and analyze the data, because these tools and approaches are newly developed. Yeah, so there is no gold standard available, so that we cannot say we have to go do it like this. And sometimes therefore the data change from year to year because of a different approach, and also due to variation in relative risk functions, for example, that vary from regions in the world and can change from year to year when new data comes available. So finally, let me summarize. I'm a bit faster than I expected, but I think I can take the final slides also for a good basis for a discussion. So I would make to aware the question, what do we really need for efficiently improving population health? And from my personal point of view, we need a lot of things and we have a lot of work to be done. So, and this would be my vision. When I heard this morning that the national cohort in Germany is in principle an approach to circumvent the problems that derive from data protection regulations in Germany. Yeah, so in principle, this is a cohort study with a huge amount of money to be done. And I think this is a good approach. It is really nice to see what the colleagues there are doing. But nevertheless, we could have such data much easier if we don't have data protection in the way we have it at present in Germany and also in Europe. So it was mentioned earlier, the Scandinavian people with their registries are much more fast forward with respect to data analysis than we are in Germany. So I think what we have to really consider is to change the data protection regulations in Germany, because we have to realize that health data is a real value. And if we have more data, I'm quite confident that we could save much more lives and that we could speed up the development, for example, of drugs or prevention programs. So what we in particular need is, this is what people told me, to better collaborate internationally at the global level, that we have better regulations for cross-border sharing of health data. So it's an issue if I want to analyze my samples in the United States and want to get back the data. I asked the national cohort in our region, what are the conditions to get data from you? And we want to analyze something. And they told me, it's about 60,000 euros to get access. So I was quite happy to hear that the UK Biobank just takes 9,000 pounds. Yeah, so Germany, 60,000 euros. So it's for academia really an issue. I'm at the university, and this is my budget from the university for about 5 years. Yeah, so I will never do this without any grant. So I have to write, I have to get the funding, and this delays the overall innovation process. And also, I think we need better access for the industry to such data, because many companies, in particular in the field of the modern tools of apps, informatics, are much more innovative than the universities are, because we are doing basic science and we do not develop tools which can be used to earn money. And I think this access to data for the industry is also a good thing we should better consider. And this all might involve a number of technological innovations and solutions for the problems. Mostly the issues refer to standardization and harmonization, likely because we have different standards in different countries. But nevertheless, one real issue for Germany is the digitalization. Yeah, that means digital collection of data, processing of data digitally, storage and provision. So please leave the paper and start to do it with the computer. Yeah, it sounds simple, but just if you look at death certificates, it is a document. It's a piece of paper that you have to prepare. So there's no way at present to do it in a different way. And we also have to develop tools that allow the better exchange without making people know from whom the data is coming. And a personal issue is, yeah, also we need better databases in other respects. So for example, on foods. Yeah, so just look at your chocolate cream, which has changed the recipe for about 10 to 15 times within the last 10 years. Yeah, so we need always to measure the nutrient content, the macronutrient content and the micronutrients in foods that are offered in the supermarkets at a yearly base. Because otherwise we do not know what the people eat. If they tell me they eat a bread roll or a chocolate cream and I do not know what the nutrients are inside, how should I calculate the impact of nutrients to disease progression? And this is really an issue because companies don't want to provide the data, although it is written on the food label. So what people are sometimes doing is really to make photos from the food products, to go to the supermarket, make the photos, to enter it into the computer. We need a food and nutrient database to have these data timely on hand, to have up-to-date data on the recipes and the composition of nutrients in our foods that we daily eat. So I think there are a lot of other things because I'm also a fan of not only having cohort studies. I think we need an electronic patient record system, which is mandatory for all of us, and which can be accessed for science, for physicians, for healthcare, and also in part for the industry to speed up the gain of knowledge and to speed up the development. I think Corona showed us nicely how difficult it is to evaluate the effects of vaccination and the complications and side effects if you do not know who has been vaccinated and who has complications. So why don't we have a registry? Yes, it's work, it costs money, it costs time, but we got valuable data from it. And also we need regularly carry out nutrition surveys, including, for example, also physical activity data, tracking data, yeah, sleeping data, which is quite important to see the effect of the lifestyle to the development of diseases. Yeah, probably it's not a good idea to give it all in one hand, but maybe we need certified bodies, maybe official or industrial institutions that collect and manage the data to harmonize and standardize everything. And from my point of view, it must be mandatory that we provide our data that we obtain from studies which have been funded from the public, that we provide them also to the GBD or similar initiatives, which is currently not being done. I asked many colleagues in Germany to provide the data for the GBD. They said, yeah, we think about it, and nothing happened. It's publicly funded data. We have to distribute the data and provide it for others to make a speed up in the whole process. So nevertheless, a final remark. So I think that tremendous big data helps us to create knowledge, and knowledge is a value and saves life. And I think this is an important thing we need to know. And this requires also the close collaboration between academia and industry. So thank you very much. And I hope that with my note, I inspired you a bit, and maybe we can have a nice discussion afterwards. Thank you.